So let me do a little bit of introduction. Today for the PM&R department grant rounds, we have Dr. Elisabeth Marsh to present. So it's a great pleasure and honor to have Liz. That's how I know you. So let me tell you a little bit about Liz Marsh. She is an associate professor in the Department of Neurology, and I'm going to read because there are many titles. Very recently, she became the vice chair of clinical operations at the neurology department at Bayview. She's the director of the Comprehensive Stroke Center in Bayview, which is one of the stroke excellence programs in Maryland, one of the two. This hospital and Bayview are the only two, so it's easy to keep track. She is the director of the Johns Hopkins Bayview Stroke Intervention Clinic, or call it BASIC. She's the associate program director of the neurology residency here in Hopkins, and the director of the Hopkins Intracerebral Hemorrhage Center. Liz has trained she's a true Hopkins person. She started her education here, undergrad at Hopkins, did the medical school here at Hopkins, residency, fellowship, and remained as an attending. So I don't think she can talk much about something else happening outside Hopkins, but maybe she can. So Elisabeth's interest obviously is in the stroke neurology, and she has written more than 40 publications. She has received funding from federal and non-federal agencies and some foundations, and she's very involved in research and training education in neurology. So with that, thank you so much for coming and joining us today.
Thank you for having me. Fair warning, I tend to walk, so I'll try to behave and stay right here. So thank you for that introduction. Oh, wait a minute. There we go. So I don't really have any disclosures for this talk, but I do ask that you keep in mind that I am a stroke neurologist. I know many of you from the floors here as well as at Bayview. So what you're going to hear is the bias of a stroke neurologist, which may be slightly different than the bias of a PMD or the bias of a rehab physician. So just keep that in mind. But I'll try to be unbiased. All right, so today I want to talk a little bit about restarting anticoagulation, which is something that you guys hear a lot. I was just with the residents, and that was one of the questions that came up that we kind of pushed for later. But restarting anticoagulation in patients that either have primary intracerebral hemorrhage or stroke with or without hemorrhagic transformation, and how we kind of think about the risks and benefits and the timing that surrounds that. We'll talk a little bit about the scope of the problem dealing with intracranial hemorrhage, and then the data or lack of data that exists. And then we'll really get into the clinical application and talk about the different factors that you can be considering. And that'll include some of the data that we've gathered here at Hopkins that help inform risk of bleeding, both with hemorrhage as well as after TPA, and some of the other questions we talked about earlier. And then finally, I'll let you know about a score or a tool that's available to you on your iPhone if it's helpful, although the neurologists often, when you consult them, will give you that information as well. So let's talk a little bit about intracerebral hemorrhage. I was telling the residents earlier that it can get confusing. So we talk about stroke, and when we say stroke, it means ischemic or hemorrhagic, but most of the time, at least as neurologists, when I say stroke, I mean ischemic. So for the rest of the talk, if I say stroke, I mean closure of a blood vessel, and if I mean hemorrhage, then I say intracranial hemorrhage. Overall, the incidence of hemorrhage in the general population is much smaller than stroke, which is a good thing because it's much more deadly. But it does increase significantly, and it increases significantly, especially with warfarin, up to 2 to 3 per 100 person years. Hemorrhage is something that affects both the old and the young, and our population's certainly getting older, so they're at higher and higher risk. And like I said, hemorrhage is really the deadliest form of stroke because you initially not only have bleeding, but have significant swelling that can cause herniation and death. So patients often look much worse with the same size hemorrhage than they do with a similar stroke early on. The bleeding risk is twice as high on Coumadin. So when somebody comes in with a hemorrhage, if they're on Coumadin, their risk of having a poor outcome is significantly worse, probably because their risk of bleeding and of continuing bleeding is worse. And many people have indications for anticoagulation now. So the risk of coming in with a hemorrhage or of having their stroke turn into a hemorrhage continues to increase. So this is an important topic to be talking about and thinking about. In addition, though, we know that we need anticoagulation for stroke prevention, right? Patients have mechanical valves and atrial fibrillation, so balancing that risk and benefit in your patient can be tricky. We also have new agents, so warfarin we know a lot about, and we'll talk about its risks and benefits, but now we have new agents that are easier to use and are becoming more attractive and more patients are willing to take. So again, the number of patients that are on anticoagulation continues to rise. So let's start with where we were a few years ago with prior data for restarting anticoagulation after hemorrhage and stroke. Let's start with hemorrhage. So initially, all we had were actually a few small case series to go on. Unlike the cardiac literature, the stroke and hemorrhage literature is a little bit behind. So we have to do a lot of looking at case series and a lot of extrapolation to figure out risks and benefits. In 2007, the American Stroke Council took a lot of these and put them together and used a meta-analysis and determined that 7 to 14 days after ICH was the optimal time to restart anticoagulation. And there was a Mayo Clinic proceeding that assembled a panel of experts. They all sat down, they looked at the literature, and they said, yeah, all right, 3 to 10 days following ICH in high-risk individuals, so people that needed to be on a blood thinner, seems like the reasonable thing. And that's where our data was about 10 years ago, which is unfortunately, we talk about things, oh, we're going to restart at this time. When you actually think about where the data comes from, you'd be surprised at the data or lack of data in many cases. It's often expert panel or consensus. In 2010, Majid and colleagues actually published one of the first multi-center, and it was a retrospective cohort analysis of nearly 3,000 patients who presented with ICH. And what they did was they looked at patients who were restarted on warfarin and that were warfarin-associated hemorrhages, and then they looked at the odds of having a stroke and the odds of having a hemorrhage to try to determine the best time to restart anticoagulation. So 234 of those nearly 3,000 patients were warfarin-associated hemorrhages, but only 132 survived the first week. So like I said, hemorrhage can be really deadly. 45 of those were started on warfarin. And what they found was that the optimal time to restart anticoagulation, unlike the prior consensus statements, was 10 to 30 weeks after patients presented with their bleed, which sounds like a lot longer, right? So why was this data so different? And that's not what we do now, so what was going on here? Well, Majid and colleagues had a bias toward lower risk indications. So they had a lot of patients in their study that had atrial fibrillation. And we'll get to it a little bit later, but what do we know about atrial fibrillation? The stroke risk is high over a year, over 2 years, over 5 years, but not tomorrow or the day after. So the risk is an accumulative risk. Unlike valves, where if you leave a patient off anticoagulation for a couple of days with a valve, your stroke risk is really high, right? So including a lot of individuals with atrial fibrillation in that population kind of skewed the data in the direction of it being safe to wait a lot longer. Whereas patients with valves were actually far more likely, of those 45 patients that got restarted, to be restarted on anticoagulation much sooner. So the population was a little bit different. Along those lines, data that came out a little bit after that by Clausen and colleagues showed that there was, that there was actually a relatively low risk after someone presented with hemorrhage of restarting anticoagulation. That the risk of having complications such as bleeding was higher in the patients that did get restarted, and it was they had more thromboembolisms when they weren't restarted. So that kind of fits with what we know, right? You don't restart patients on their anticoagulation, a small portion will go on to have a stroke, you restart them on their blood thinner, and a small portion will go on to have a bleed, right? That makes sense. That's not entirely helpful, but at least it's intuitive. And then this Danish registry came out that, again, looked at patients with AFib, and you can say, well, why did everybody keep looking at AFib? It's because that's the biggest group of patients that we have that requires anticoagulation, right? And they're often recruited for cardiac studies, so it's very easy to take that and then take that data and find out information for stroke and hemorrhage. And what they found was similar to what we know, that when you anticoagulate, the risk of stroke goes down over time, and you can see it goes down a little bit if you start an antiplatelet agent. And it goes down even more if you start an anticoagulant. But the risk of recurrent hemorrhage goes up with each of these. So then what people ended up doing is they put data together, right? More numbers gives us more data. So people love meta-analyses. And that was where we were really left in around 2010 or so. And in fact, here at Hopkins, we did a nice meta-analysis, and we determined that high-risk individuals should be started on anticoagulation, and that they had a high risk for stroke, and that we should wait a few weeks after and then start them. Probably the best data that you guys have heard about came from this study here, where the 7 to 8 weeks is thrown around. And this came from a study from 2005 to 2012 that looked at 2,619 ICH survivors with atrial fibrillation, and found that when patients were started within the 7 to 8 week time period, they had a lower risk of hemorrhage and a lower risk of stroke, and that seemed to really be the sweet spot. So now often we'll put in our recommendations that a patient presents with a hemorrhage, they have a risk for they have an indication for anticoagulation, and start 7 to 8 weeks after. So it's good to have data, right? It's good to have these studies, but I just told you that each of them has weakness. A lot of them just included atrial fibrillation patients, and all patients aren't different, right? And we all practice and need to think about our patients as individuals. So what goes into really weighing the need for the risk and benefit of anticoagulation? And that's what I want to spend a lot of the rest of the time talking about, and how we think about that need, and why some of the recommendations are going to be different. And the things, really the key factors or the key players that go into this decision are etiology of the bleed. Why did they do it? Is there a trigger? What's the indication for anticoagulation? What is the agent that we're going to use? So is one safer than another in helping me to mitigate that risk? And then other risk factors. So should anticoagulation be restarted at all? Right? There's a group of people that think that once a patient bleeds, we're done, no more anticoagulation. Maybe that's true for some patients. And then how long do we wait? So let's think about the etiology of the hemorrhage. So for me, I'm always looking for a precipitating factor. So a patient comes in with a blood pressure of 200. That doesn't necessarily tell me that their blood pressure is out of control at baseline, because every hemorrhage patient comes in with a blood pressure of 200. That's how they present. But being able to get a little bit more history and hear that they have uncontrolled hypertension makes me happy. Not because they have uncontrolled hypertension, but because I have a trigger and I have something that I can modify that will then decrease their risk. The same is true for trauma, right? If they fell, I know why they had the hemorrhage. Or if their INR is super therapeutic and is 4, I know what led to their increased risk. The person that comes in that's INR is 2.5, right where it's supposed to be, that always takes their blood pressure medications, and that had no other precipitating event, I cringe because I don't have anything to modify that's going to help me to decrease their risk if I start them back on anticoagulation. It doesn't mean I don't, but I certainly don't feel as good about it, right? I don't have anything to modify. I also look at underlying vasculopathy, and what do I mean by that? So we talked a little bit with the residents earlier about imaging. We didn't talk about this one. So up here, this is gradient echo imaging. And you can see these little black dots. That's hemorrhage or microbleeds. It doesn't tell me whether they're new or old, because little black dots can happen when they're babies or when they're adults, and it looks the exact same. But the pattern does help me. So these deep bleeds in here are a classic hypertensive pattern. When I see a gradient echo that looks like that, I know that person's had hypertension a good long time. When I see these microbleeds here in the cortex, I get a little bit nervous, because that's where amyloid tends to hang out. People start to have a little bit of dementia, they come in and on their gradient echo, they have these microbleeds that are more cortical. Patients that have amyloid angiopathy have a known risk of incredibly high recurrence, both for micro and macro hemorrhages. So a patient that has an ICH due to amyloid is not someone that I would restart on anticoagulation. We're going to think about it for everybody else, but for me, that's a hard stop, because the odds that they're going to present with another hemorrhage and that it's going to be a huge hemorrhage and kill them is incredibly high. And any type of risk prevention for ischemic stroke is going to pale in comparison to that risk. So one of the first things I think about is, did amyloid play a role, and are there modifiable trigger risk factors? Okay, does that make sense? So I thought about the hemorrhage risk, and I thought about why they had their hemorrhage, and now I need to think about why they need to be anticoagulated, right? Is it worth it? Are they 99 years old and really, really sick, and it's not going to make a big difference over time? Or do they have a risk factor? So indication for anticoagulation informs both when and whether I restart anticoagulation. So some of them are really easy, right? Somebody has a DVT or a PE, they have active clot. I don't have a choice, right? Then what I can say to you as a neurologist is, ooh, we're between a rock and a hard place. I'm really nervous they're gonna bleed, and we'll talk about how I quantify that. But you know what? You have no choice. You gotta go ahead and restart it. They have a DVT, right? And maybe they're not a filter candidate. Or they have a PE. You got to put them on a blood thinner. Or they have a mechanical valve. So the risk of stroke with mechanical valve, particularly a mitral valve, is incredibly high. The cardiologists range anywhere between allowing a patient to be off 1 versus 4 days before they start to get a little bit anxious. So I really have to start thinking about, okay, how long can I wait to restart a patient on anticoagulation with a valve? And what am I going to tell the patient and the team about their risk? Because holding it really is not an option in these individuals. But that's a little different than some of these other risk factors, right? And we started to talk about some of them earlier, but atrial fibrillation is the big one. And by far, you could see in the studies, the major reason that patients are on anticoagulation. You're gonna see far more patients with AFib than you're gonna see with mechanical valves. And here the picture's a little bit less clear, right? So we know based on their CHADS-2 or their CHADS-VASc score what their risk on a daily basis or on a yearly basis is for having a stroke from atrial fibrillation. But again, remember, it's an accumulated risk over time. So you may have a patient who's high risk overall, who I want to restart anticoagulation on, and that's my stroke bias, right? So a lot of primary cares are like, oh, they're 90, I don't want to start. I start everybody on anticoagulation because a 90-year-old that has a stroke is going to die from their stroke. But we'll talk about that in a second. But the CHADS-VASc score, the CHADS-2 score, tells me about their risk and makes me decide whether or not I'm going to start them. But again, I'm thinking longer term, not necessarily 4 or 5 days after their hemorrhage. So this is what I was getting to with stroke due to atrial fibrillation. The problem when people have strokes due to atrial fibrillation is the strokes aren't little. So when you have a stroke that's due to a cardioembolic event because the heart's not beating properly, right, a big clot forms. It's not like the little clots that form in the blood vessels that go to the brain. They cause problems, but they're smaller, right? They're often a scatter shot. These clots are big. They lodge in the MCA, they lodge in the ACA, they lodge in the basilar, and they cause debilitating strokes. So if I can prevent that with anticoagulation, then that's going to be my preference. And I understand people bleed, but their strokes are devastating when they stroke due to atrial fibrillation. There have been lots of trials for primary prevention, if you like alphabet soup, and secondary prevention showing the effectiveness of anticoagulants, predominantly warfarin here, but we're accumulating DOAC studies currently. Heart failure is a little bit trickier, okay? So we have a strong indication for atrial fibrillation, but what do we do for heart failure patients? So this is based on the WARSEF study. The WARSEF study came out a couple of years ago, and it looked at all patients with heart failure with ejection fractions of 35% or less. And it followed them over time. It didn't care whether you'd had a prior stroke or not, but it looked for the risk of recurrent stroke. Okay, and about half of the population was on an antiplatelet, and half of them were on a blood thinner. And this group had not had evidence of atrial fibrillation, although they weren't screened intensively. They didn't have loop recorders or anything implanted, but they hadn't had any history of AFib. And when they followed them over time, they found that for both groups, for the group on aspirin and warfarin, the recurrence of stroke was small, or the stroke period, because some of them were primary strokes, initial first strokes. But that after about 4 years, you can see that the warfarin group did better. They had less strokes, which tells us, how I interpret that graph is that if your patient's going to be around for 4 years or more, there starts to be a benefit for warfarin in decreasing the stroke risk. And remember, we're talking about big clots because they're coming from the heart again. Now, I do have to point out that they're small, right? There's a small benefit, and a lot of primary cares don't think it's worth it, which is reasonable. But the subgroup analysis that looked at patients that had had strokes, so for secondary prevention, was much stronger. And that's the group of patients that I see. So I tend to push hard for people that have already had strokes with heart failure to be restarted on anticoagulation. But I don't look at it like a mechanical valve or even AFib because the data is not as strong and isn't there. You see how we're starting to slowly decide what our threshold is for saying someone needs to be anticoagulated versus not and starting to think about time? Okay. How does a choice of anticoagulant help me decide what my treatment plan is going to be, or what am I thinking about? Well, we now have three, heparin, Coumadin, and the DOACs that are available to us. Not to make everybody cringe about their biochemistry, but to take us back. So heparin is a glycoaminoglycan, and I won't ask anybody about the clotting cascade. But the nice thing about heparin is that it's able to be stopped and able to be reversed, right? You can turn it off immediately when they're on a heparin drip, and you can reverse it with protamine, which is great. There's also the low molecular weight form. Unfortunately, it's in the form of shots, which a lot of patients don't like. But the nice thing about heparin is it's metabolized in the liver. It binds to the platelets and the plasma proteins. This is in comparison to warfarin, which is nice because it's an oral form, and has other advantages. So we know a ton about warfarin because it's been around forever. We know the good, the bad, and the ugly, right? And there is bad and ugly, right? It interacts with a lot of medications. It interacts with a lot of foods. Patients have to have their INRs monitored. So there's a lot of things that aren't going for it, but it is an oral pill, and we do know what to expect, and we do know how to monitor it, and we can give vitamin K to reverse it. So all those things are good things. Then we have the new agents, right? And just to get everybody on the same page, because I know I always have to think about where they work very differently, right? So we have dabigatran, which works on, which blocks thrombin's ability to convert fibrinogen to fibrin, which you need for clot. And then we have the 10A inhibitors, which also interfere with that pathway, so that fibrinogen is not being converted to fibrin, and clot is not building up and forming. So dabigatran was first approved in 2010, and it's a prodrug. And the nice thing about it is that it acts on thrombin, and it has a relatively short half-life compared to warfarin. And there's no need for monitoring, which is the reason the patients like it so much. It acts quickly, so you give it, it starts working, and now there's an antidote, which we'll talk about in just a second. The problem with dabigatran is that it's predominantly renally excreted, so if patients have renal impairment, and a lot of ours do, that can be an issue. And in the past, some of the other similar medications had some side effects that didn't make it ideal, although dabigatran seems to be fine. What a lot of us prefer are the factor 10A inhibitors, and there's three of them now, although the top two are really the ones that are mainly used, rivaroxaban and apixaban, that were approved in 2011 and 2012. They're also orally available, and they have a very predictable onset and plasma concentration. And they're not affected by age, renal disease, hepatic disease, any of those things. They still don't require monitoring. They have a short half-life and a rapid onset, but they don't have an antidote, which at least not yet, although the pharmaceutical companies are working on them. The issue with that, and the way I think about that, is that they actually have a lower bleeding rate, probably because they keep people in that range as opposed to having fluctuating levels of INR. And Coumadin, its antidote's vitamin K. That's not actually how we treat a Coumadin hemorrhage, right? When someone comes in with a Coumadin-related hemorrhage, we do give vitamin K, but that takes hours to days to actually work. We give PCC and other clotting factors. That's the same thing we give for the 10A inhibitors. So patients get really agitated, and some doctors do as well, that there's not an antidote yet, and I think we'll all feel better when there is, that's approved and used routinely. There's certainly some that are very close. But it's less of an issue for me as a stroke neurologist because, again, we treat this the same way that we treat a Coumadin hemorrhage. And we know, based on the literature so far, that these patients actually do better, probably because they're in range more frequently than the Coumadin patients. Oop. Oh, well, that didn't go well. Anyway, these trials, these were big trials just showing that for the DOACs, which they're not NOACs anymore because they're not new enough, so now they're direct instead of being new. They were effective in preventing recurrent stroke. So how do I think about these three classes of medications, or these three medications, when I'm going to choose an anticoagulant for someone that's had a hemorrhage? okay? And I'm gonna restart. Well, so for heparin, right, it's pretty straightforward. It's easy, you can turn it on, you can turn it off. So if you're really worried about somebody bleeding, it's great. It's a great way to hedge your bets. Oh, they have a mechanical valve, I really think they need to be on something. Let's try it. We'll re-scan them, we'll make sure that they're not expanding. I can turn it off rapidly, I can reverse it, right? For Coumadin, it has its benefits too. I like the fact that I can start it and that the INR isn't therapeutic right away. So I can start it on discharge in somebody that I'd like to wait a few more days to be anticoagulated, and it will slowly drift up into therapeutic range. We certainly do that. I think we've sent plenty of patients to rehab with you that way, right? Where we're watching the INR drift up. We know how it's going to interact, but we do need frequent monitoring. And then there's the NOACs, right, that have less interactions and are immediately therapeutic and easier to monitor, but we don't have the antidote. We're going to put this all together at the end, and we're going to do some cases and see how each of these pieces fits into our decision-making about when to start anticoagulation, if to start, and what we're going to use. The last piece is other factors that increase the risk of hemorrhage, right? And this is where we have more accumulating data. So what's specific to my patient, all right? What do they have? And there have been a few scores that have tried to quantify that. So the Hasbled score from the EuroHeart study, as well as the Hemorrhages score, try to say, what about this patient? Is it their platelets? Is it their renal failure? Is it their kidney or liver function that makes them more likely to bleed? And what does that bleeding risk look like? The problem with all of these studies is that they don't have many intracranial hemorrhages. They have GI and GU hemorrhages because they're from atrial fibrillation studies. No study was dedicated exclusively to risk factors for ICH. And that came to one of the reasons for a project that we looked at in neurology, where we wanted to know, and this was in ischemic stroke patients, okay? But we wanted to know what factors made them more likely to bleed. So we've talked a little bit about hemorrhage patients where we know they've already proven that they've bled, but in the way we think about them and when we restart anticoagulation. But what do you do with the ischemic stroke patient who they probably had their stroke because they have atrial fibrillation and now they need to go back on? What are factors that inform our understanding there? And that's the group that we looked at, and then we tried to see if we could also apply that to primary intracranial hemorrhage. So we took 143 patients with acute ischemic stroke, and 117 of them were anticoagulated. They got restarted in the hospital for high-risk reasons, and 26 were not. And what we found is that the hemorrhage rate actually wasn't that different between the two groups. It was slightly elevated in the anticoagulated group, but that you can see that the symptomatic hemorrhages occurred in that anticoagulated group, which makes sense, right? So you start somebody on a blood thinner, and most of the time in these patients it was warfarin, and their risk of having a symptomatic hemorrhage is higher. But what were factors that helped us to know what the likelihood of that was? And when we did our analysis, what we found was that the NIH stroke scale score, which is a good surrogate for how big the stroke is, right? It measures stroke severity. You get more points for the things you can't do. You can't lift your arm, you get 4 points. You can't look in all directions, you get points. And renal failure, which was interesting, and we're going to talk a little bit more about. So another word about volume, just dividing our cohort into tertiles of volume. So smaller and larger strokes. The larger your stroke, the higher your risk of having symptomatic hemorrhage. So your risk of hemorrhage actually increased 14% for every 10 cc's of ischemic tissue. And we talked about this a little earlier with the residents, but why is that? It's because when you close off a vessel and brain tissue dies, all of the little vessels that feed it become friable. They're damaged, right? They're not getting, they're at higher risk to be leaky and higher risk to have hemorrhagic transformation when you actually start thinning the blood. So this makes sense. What was interesting, although intuitively also can make sense, is that renal impairment was associated with a higher risk of intracranial hemorrhage. So patients that had no renal impairment had a 20% risk of any conversion. And when you have a big stroke, a little bit of hemorrhagic transformation, a little bit of conversion, a little bit of oozing is actually quite common. It doesn't cause new symptoms, but it's quite common just because those vessels are friable. Whether or not it causes problems helps us to categorize it as asymptomatic or symptomatic, okay? But your odds ratio of having any bleeding goes up by 1.5 if you have mild renal impairment, so your GFR is a little bit a little bit poor, and goes up 2.8, so nearly threefold if you have moderate renal impairment. So your GFR is less than 30. Okay, so another risk factor for patients having more of that oozing. And that allowed us to actually create a score, and a lot of times you hear this from the residents, called the Hemorrhage Risk Stratification Score, or the HERS score. And it allows us to actually say to you, look, this patient's had a stroke, we know they need to be on a blood thinner, but this is their risk of having hemorrhage. Or we don't know if they need to be on a blood thinner, we're weighing the risks and benefits. What's the risk of stroking? Let's compare that to what we know the risk of hemorrhagic transformation is. And this score uses stroke size, renal failure, and age as its variables. And it's actually available as an app that can actually quantify for you, again, based on those factors, what the percentage likelihood of bleeding is. And I find it really useful to be able to talk in actual numbers, whether to a physician or to a patient, right? Because have you ever tried to give a patient advice and said, well, the risk is small, and they're like, what do you mean by small? You're like, small, small. Well, small as in 5%, small as in 10%. What does that actually mean? And this is a nice way to help quantify that. We actually validated the score at a new cohort and found that it was helpful in predicting, so it wasn't just the cohort that we developed it in. And then we started looking for other areas where renal impairment was important and how that helped to inform our what we know about bleeding risk. And we looked at patients with TPA, and somebody asked me about this earlier. So we actually looked at our entire population treated with IV TPA over several years and found that 18 of the treated, 8 of them bled, and 3 of them with renal failure bled, so a higher risk. And when we went back and did a retrospective analysis of 224 patients presenting with symptoms, what we found was that the creatinine greater than 1 was a big predictor of a 5.5-fold increase in symptomatic hemorrhage in patients that got TPA. So you can see here that the patients, you can't see that the patients with symptomatic hemorrhage significantly increased if they had TPA. So our average bleeding risk for TPA is about 5 to 6%, but patients with renal impairment were certainly on the high end of that, which is important, but the other important thing to note, because people get worried, is that patients without renal impairment, their risk of bleeding was like 1%. So not only do patients with renal impairment do a little bit worse, but your risk is really almost negligible if you don't have renal impairment, if you get TPA, which is important and I think clinically useful. We also found that renal impairment makes the risk of having big hemorrhages as opposed to little hemorrhages far more likely. And this has been shown in the literature and is consistent with some of the things such as the Rotterdam study, which showed that a decreased GFR was associated with a 4-fold increase in hemorrhagic but not ischemic strokes. And to some studies looking at microbleeds. So remember those tiny little areas in dialysis patients. They tended to have more than non-dialysis patients. And where does that come from? Well, it may come from the fact that, when you're uremic, your platelets don't work. Okay, there's a platelet dysfunction that we don't quite understand, but that we know occurs. Or the inflammatory cascade that occurs also inhibits coagulation factors. So after we found that renal failure and volume were important in hemorrhagic transformation, we wanted to go back to our initial question about whether or not it was important for primary hemorrhage as well. And what we did is we looked at a group of patients with small vessel disease. Because small vessel disease puts you at risk. Those patients can either get lacunes, right, which are ischemic strokes, or they can have deep hemorrhages. And we wanted to see what the effect of renal disease. Does it make you more likely to have ischemic or hemorrhagic disease? And what we actually found was that there were factors that were more predictive of one versus the other. So patients with similar vascular risk factors with small vessel disease were more likely to present with small, deep hemorrhages if they were older, if they were African American, and if they had microbleeds. And they were more likely to present with small vessel lacunes if they were female and had more extensive white matter changes. And you can see that for this, renal impairment didn't go either way, probably because it's a risk factor for both. Okay? So what does that help us to understand, and what is kind of the unifying themes here? So in patients who present with an acute stroke who also need to be on a blood thinner, age, stroke volume, and renal impairment are the most important factors in thinking about what their risk is for bleeding. And that those who are on anticoagulation, who you do have to put on, don't necessarily have a higher risk of bleeding, right? Remember those two numbers were pretty similar, but they're more likely to be symptomatic, to have oozing that's symptomatic and causes a worsening exam. So something to think about. Patients that are given TPA, when they have a creatinine that's greater than 1, their risk of having a symptomatic hemorrhage is higher, though not ridiculously high, still within treatment, the national guidelines, but that those who don't have an impaired creatinine have a very low risk of bleeding. And in patients with long-standing hypertension that we see, those who are older, African American, and have microbleeds are more likely to end up coming in with a hypertensive hemorrhage as opposed to a hypertensive lacune. And why is that important? Well, I told you at the beginning, right, that those hypertensive hemorrhages actually don't do as well early on. Right? The lacunes, they can cause problems, they can cause a hemiparesis, but ICH is a far more deadly illness, particularly early on. So how do we apply all that we know about the risk factors that are important for hemorrhage, both primary intracerebral as well as hemorrhagic transformation, and think about restarting anticoagulation in our patients? Let's do a couple cases. All right, so I have a 68-year-old guy who has a history of hypertension and a mechanical mitral valve, so high risk. He comes in with a 30 cc hemorrhage and an INR of 5. Okay. So what do you guys think, pros versus cons of anticoagulating, period, about the etiology of his hemorrhage? What do you think? Was it triggered? Are there things we can modify? The INR was super therapeutic. Great. Love it. How about the indication for anticoagulation? Does he need to be anticoagulated? Yeah, he has a valve, right? I'm with you. How about other risk factors? Ooh. He doesn't have a whole lot of them. Okay, so what do you want to use? He has an active hemorrhage, but a valve. How about some heparin, right? Okay, so he's only a day out. Okay, over time, those friable vessels start to heal, but not at 24 hours. But I don't want to wait that long, right? Or how long do I want to wait? He has a valve. I don't want to wait more than a couple of days. So I would start heparin in as long as cardiology will give me, right? 3, 4, 2, whatever they're comfortable with, but not very many, less than a week. Okay, so I take as much time as I have, let it heal as much as I can, and then I would restart, and then I would start heparin, and I'd watch him very carefully. Does that make sense? Let's try another one.
Did you rescan them at a particular time, 24 hours, 48 hours?
So I often will, so I rescan for symptoms, absolutely, hands down first thing. And then usually after they're therapeutic for 24 hours, I'll rescan them also. The problem with that is that what are you gonna do with that information? If they've expanded a little, are you gonna stop? Right? So you gotta know what you're gonna do with the information you have. We do it because we wanna know, but it's something to think about. Right, if they're asymptomatic and have expanded just a bit, are you gonna wait another 6 hours and scan again? Right, so then it becomes a little bit dicey, but I tend to rescan after 24 hours because it is a person I'm worried about. Yes, sir?
So why do you do it? Because you just said.
I know, because theoretically if somebody does expand, their risk of expanding further is high. Well, then I'd probably rescan in 6 hours and make sure that it stayed stable. I would serial scan. But you're right, you're opening Pandora's box. But I do worry, and if they're that guy has an active hemorrhage. I'd be hard pressed to find a neurologist who wouldn't scan at 24 hours. But you do have to think about what you're going to do with the results.
How long do you keep scanning?
So if it expanded just a little bit.
Oh,
if it didn't scan, I would, no. I scan once, it's stable, and then if they're symptomatically the same, I don't scan again. Because again, what are you gonna do, right? But symptoms, absolutely. The other thing, and I'll just say this here while we're talking about scanning, I often like to get a baseline scan period, especially with big strokes, because again, we talked about how a lot of them ooze. The worst ever is to send somebody out and say, just start your anticoagulation, and then somebody gets a headache or somebody gets delirious and you scan them and there's a little bit of blood and you have no idea if it's just because they have a big stroke and it's the natural course or because you started their anticoagulant. So for that reason, you'll often see us, we'll get a baseline scan before we send them right on their way out the door. And it's okay if they have a little bit of hemorrhagic transformation, but that tells me it's there when they're looking good or looking the way I send them to rehab, so that in rehab, when somebody fluctuates or has an issue, you know what to compare to. Because it does, it's a very natural thing to have a little bit of hemorrhagic transformation in those big strokes over time. All right, let's try another one. 78-year-old woman, she has atrial fibrillation, so think about her long-term, short-term stroke risk, on Coumadin, who comes in with a 50 cc hemorrhage, okay, so pretty big with some involvement of the ventricles, after she fell. Her INR is 2.5, so in range, and she has a normal blood pressure. Okay, so the etiology of the stroke, what do you think? She fell, love it, great. Does the INR help you? Man, wish she'd been therapeutic. No, she's therapeutic, right? And her blood pressure is normal. Okay. How about indication for anticoagulation? She has AFib. So good reason, right? But not necessary for right now, okay? How about other risk factors? She's falling. Okay, so what do you know about anticoagulating someone who falls? What do you know about the risk? This is, again, I'm putting on my stroke neurologist hat. The primary cares don't like it. So there's actually a really nice paper, and I can send it to you, in looking at patients with AFib and anticoagulation. You have to fall every day to make your risk, when you have an elevated CHADS VASC score, to be fair. I think actually they did it with CHADS 2 scores, but to make your risk of having an intracranial hemorrhage, now we're not talking GIGU, so separate issue, happens more frequently, but to make falling and having an ICH outweigh the risk of, again, having a large stroke. So something to think about, and every patient's different, and there are certainly patients who fall all the time who maybe you're thinking about not doing it in. But in general, don't use a fall like that as an excuse not to anticoagulate a high-functioning individual. Think about it, but there's significant repercussions to that long term. Okay, so what agent do you want to use in her? Yeah, I think restarting her on whatever she was on before would be absolutely reasonable. So I think Coumadin or a NOAC, I don't feel, when do you want to do it? Do you want to use heparin now? Do you want to when do you want to do this? So she has AFib. Yeah, so I think waiting, I would even wait longer than that, right? That paper that came out that's saying, 6 to 7 weeks, 7 to 8 weeks, with a primary hemorrhage, although it was triggered, would not be unreasonable. So certainly waiting weeks and into her rehab stay. And you'd probably get some kind of recommendation right around 1.5 to 2 months in thinking about restarting here. That would be entirely reasonable. But see how she's not going to get the heparin, she's going to kind of get a different course. How about this one? I have an 88-year-old man with an ejection fraction of 25%. So he meets heart failure criteria, who comes in with a left MCA syndrome. And this is a diffusion scan. So remember, bright is acute stroke. This is a new stroke, happened in the last week. There's a big cutoff here, no left MCA. Right? So he has heart failure and had a big stroke. So etiology of ICH, well, he doesn't have an ICH, okay. How about his indication for anticoagulation? What do you think? He has heart failure. It's not the strongest, right? I told you there's some data that Coumadin is better than aspirin, but aspirin does okay. So it's not the strongest. It's certainly not a hugely compelling reason. How about his other risk factors? We don't know much. Well, we know we can calculate his HERS score, right? So we know the guy is 88, he's old. We know the guy has a humongous stroke. I didn't tell you his renal function, but those two things alone make his HERS score, his likelihood to have any hemorrhagic transformation, almost 60%, which is huge, right? So he's a guy that I would use aspirin in, right? I don't think the benefits outweigh the risk. So in summary, Weighing the need for anticoagulation versus the risk is really important, and that helps you to answer the questions about should anticoagulation be restarted at all, and then when do you restart it? Acutely, and if so, how do you do it? Do you use heparin? Do you just let the INR slowly go up? And the ways to think about that is really to think about the etiology of the hemorrhage, whether it was precipitated and there's something that you can modify, and the indication for anticoagulation, whether it's emergent, whether you gotta do it today or in the next couple of days because they have a valve. Also thinking about the agent and these other risk factors, and not forgetting about the importance of renal impairment, which a lot of our patients have. With that, I think I'll stop, and I'm happy to take any questions about this or about other stroke-related topics. I know there's a lot of discussion. We had some great discussion with the residents about some other questions, and I'm happy to talk about them.
So how much the size of the stroke, how much brain you have left after you have these strokes? It's your decision of moving on to an aggressive prevention.
Mm-hmm.
So you clearly show the larger the size of the stroke, the more likely your risk for bleeding, but also the less piece of brain that you have left to work with, and then you have seen the risk. You assume that the person also will have more complete immobilization, falls, and so on. Those risk factors increase. So is that part of the conversation when you start thinking anticoagulation in the long run?
Well, so I think that would be, absolutely reasonable in thinking about an older individual. So like someone who's 90 who wasn't good before their stroke, that has atrial fibrillation and comes in with a humongous stroke, they've already taken out a hemisphere, and what exactly, how long are they going to be left? To really reap the benefits from being put on an anticoagulant, I think that's a perfectly reasonable thing to think about. As opposed to the 45-year-old who came in with a hemispheric stroke, they have a lot of potential to recover and a lot of years left to potentially have an increased risk. So no, I think that that's a very good thing to think about. Yes?
Great talk. So obviously there's another group of patients that we anticoagulate less, which is DVT prophylaxis.
Mm-hmm.
Full anticoagulant.
Mm-hmm.
But is there any data out there about when it's safe to do DVT prophylaxis?
So in general, DVT prophylaxis is fine to start as soon as, so we talked about how it's 24 hours after IV TPA, but it's fine to start once you've shown that if they're hemorrhage, that the hemorrhage is stable, and that stroke fairly acutely. The risk of DVT is incredibly high in those patients because the brain, for hemorrhage, the brain doesn't like the fact that it's bleeding, so it actually becomes procoagulant to some effect, plus you're immobilizing people. So their risk of clot is very high, so we start DVT prophylaxis as soon as we show the clot is stable. Or it's not the clot, the blood is stable. Mm-hmm. Often within the next day, yep. Yes, sir.
So you talked about old people and younger adults. Are there any special consideration for pediatric patients who might have a bleed, like on arterial venous malformation or something?
Oh, that's a great question. So the arterial venous malformations are a different bird altogether. So they are an incredibly high risk. They're in a high pressure system, right? So when you put an artery and a vein next to one another and it starts pumping in, we cringe about anticoagulating those individuals without having them fixed. I usually don't. They're incredibly high risk to bleed.
Are there any other pre-morbid medical situations that would argue against anticoagulation? For example, let's say someone had Parkinson's disease, pre-morbid factor that went on to stroke. Would that, they had mobility deficits associated with Parkinson's, would that be an additive factor to consider not anticoagulating?
So he's asking about comorbidities. So I think it's about, that factors into the discussion about how long you have to be on a medicine to reap the benefits of the secondary prevention. So if their Parkinson's is so bad that they only have, 6 months to a year left, that's then probably that person isn't going to achieve significant benefit. If you're thinking about it from a falls perspective, at some point, once they're wheelchair bound, they're not falling anymore. right? So that almost makes it easier. So I think having that trade-off, also having a family discussion about what would be worse. So is a major stroke worse than, some of these other alternatives? Because thinking about a big stroke from atrial fibrillation is going to put the patient's done. They're in a nursing home. They're not leaving. Weighing that against, some of these other risks and putting that into perspective for the family so that the family can think about some of these things. They're hard discussions. There's not an easy right answer, but there are certainly things to be thinking about. Yes, sir.
Is there any special consideration for those who definitely do require TPA to get it, and have a history of microbleeds, so their risk for bleeding right after the time, and they do. Is there any special consideration for certain anticoagulation someone who has to does definitely need anticoagulation for those who bleed right after?
That's a great question. So let me answer two questions. One you didn't ask but almost asked, and the other one you did. So as far as microbleeds and TPA, so you are correct that if you look at patients that have been scanned, that their bleeding risk is higher with TPA if they have more than 10 microbleeds. However, it is still incredibly low and not at all worth scanning patients with MR prior to determine whether they have microbleeds. I want to say that again because otherwise it's going to become, Liz Marsh said we shouldn't give patients with microbleeds TPA. It is an incredibly low risk still, but there is some data to show that if you have more, that their risk is slightly higher of having hemorrhagic conversion with TPA. If patients have hemorrhagic transformation with TPA, I certainly think about those things a little bit differently. So who has hemorrhagic transformation? Usually big strokes, right? So the smaller strokes don't have conversion as much as the bigger strokes do. So it factors into my analysis. Well, I knew big strokes bled anyway. And yes, once you've bled, then am I going to probably wait even just a little bit longer? Sure. The same thing for if they have a lot of microbleeds. That in and of itself doesn't, unless they're in the spot for amyloid, it doesn't factor in quite as much. But if they've proven that they bleed, right, once you've proven you've done something, you're kind of showing that that's the path you're on. So that's I'll give you an example, a patient with atrial fibrillation, right, you put them on anticoagulation, they have a hemorrhage. You take them, so they have never had an ischemic stroke. They've now shown you they've had a hemorrhage. So you waffle a little bit and think, again, you look for modifiable risk factors. Maybe that person's INR was 6, great. Then I might restart them. If their INR was right where it was supposed to be and they had a hemorrhagic transformation on therapeutic warfarin, that's a harder decision because they've shown you that they're a bleeder, not a stroker. And that piece of history does have something, at least a small part in decision making. There aren't right answers. That's a good thing and a bad thing. There's a lot of gray, but thinking about how to approach the gray so that you're consistent and so that you have a frame of reference is really important, and why doctors are important, right? Otherwise you could just plug it into an algorithm and it would spit out and tell you what to do and how to do it, right? But there's clinical decision making involved. Great. Thank you.
So there is a new code for the texting things, and it works.